Today we will start with the high altitude physiology. Uh, but first, let me give you the unit outline. We will have a look at aviation, high altitude, and space physiology. And then we will move on to the physiology of deep sea diving and other hyperbaric conditions. Our chapter 44 includes the effects of low oxygen pressure on the body, and then we will see the effects of acceleratory forces on the body, either in aviation or in space. Then I will introduce you to artificial climate in the sealed spacecraft, after which we will look through the effects of weightlessness in space. Now, you might be wondering that why you have to study this chapter at all. Because, my dear, the aeronautical advancements have made it increasingly more important to understand the effects of altitude and extraterrestrial conditions on human body. Now, first of all, I'm going to introduce you to the term atmosphere. You see, it is the medium in which aerospace physiology occurs. The physical atmosphere from the surface of Earth consists of 5 layers, you can say. And these are troposphere, stratosphere, mesosphere, ionosphere, and exosphere. Now, if you look closely at this figure, you can deduce important characteristics of different spheres, such as troposphere. It contains clouds, and the temperature falls with the altitude in this sphere. Uh, the stratosphere, it includes ozone layer, while in ionosphere, as the name is suggesting, the ultraviolet and the gamma irradiation produces ions. While we are studying high altitude physiology, you must know that what is this critical altitude? You see, up to 10,000 feet, no signs and symptoms of severe abnormality appear except mild hypoxia, to which a person can acclimatize easily. So, high altitude is above 10,000 feet, while 18,000 feet is the highest altitude where permanent inhabitation is still possible. Now, above 20,000 feet, hypoxia endangers life, so oxygen is needed. Now, the question which should arise in your tiny brains is that how do modern aircrafts fly above 35,000 feet, carrying travelers comfortably? Actually, in these planes, pressurized cabins provide environment similar to that at sea level. And then above 40,000 feet, there is ozone layer. Since you know now what is high altitude, so let's start with its physiology. Uh, Here are the learning objectives which you must know by the end of this lecture. So let's first see the effects of low oxygen on our body, and then I will tell you that how do we get acclimatized to this low oxygen on high altitude. As you can see in this chart, that with increasing altitude, pressure of air decreases. But keep in mind that its composition remains same. According to Dalton's law, total barometric pressure of air is the sum of partial pressures of all gases, as you can see in the equation. Since the partial pressure of water and the partial pressure of carbon dioxide, they are determined by the body itself, so they do not change much with altitude. Only the partial pressure of oxygen and that of nitrogen, they change. Now you can see that an acute exposure to a decrease in barometric pressure, that is the basic cause of high altitude hypoxia. And this chart is showing barometric pressure at different altitudes. And you can conclude from it that barometric pressure decreases at increasing altitude, because you see at sea level the barometric pressure is 760 millimeter of mercury, while at 10,000 feet it is only 523 millimeter of mercury. Further going up at 50,000 feet, it is only 87 millimeter of mercury. Now you can also observe alveolar partial pressure of oxygen at different elevations to conclude that as the pressure decreases, the atmospheric oxygen partial pressure decreases proportionately. Also that the partial pressure of oxygen remains at all times slightly less than 21% of total barometric pressure. That's why at sea level, the partial pressure of oxygen is 159 millimeter of mercury, but at 50,000 feet, this partial pressure of oxygen is only 18 millimeter of mercury. So, by all means, now it is clear that as altitude increases, both barometric pressure and the atmospheric partial pressure of oxygen decrease proportionately. Unfortunately, alveolar partial pressure of the oxygen, that is further reduced by carbon dioxide and water vapor pressure. But how? Well, let me explain. Let's assume we are at Babusar top in the northern areas. Now the carbon dioxide is continually excreted from the pulmonary blood into the alveoli, and water also vaporizes into the inspired air from the respiratory surfaces. So these two factors dilute the oxygen in the alveoli, which results in reduction in oxygen concentration. Actually, the alveolar partial pressure of carbon dioxide falls from a sea level value of 40 millimeter mercury to lower values as the altitude increases. And in an acclimatized person with a five-fold increase in ventilation, the partial pressure of carbon dioxide can be as low as 7 millimeter mercury because of the increase in ventilation. Now the water vapor pressure in the alveoli, it remains at 47 millimeter mercury as long as the body temperature is normal regardless of altitude. You might still be wondering that how carbon dioxide and water vapor pressure reduce the alveolar oxygen tension. You see the barometric pressure, it is 253 millimeter mercury at the top of Mount Everest. Now, out of this 253, 47 millimeter mercury must be water vapor, right? Leaving a 206 millimeter of mercury for other gases. And then in an acclimatized person, 7 millimeter mercury of this 206 millimeter mercury must be carbon dioxide, leaving only 199 millimeter mercury. Now, if there were no use of oxygen by the body, 1/5 of this 199 millimeter mercury would be oxygen and 4/5 would be nitrogen. Or you can say the partial pressure of oxygen in the alveoli, it would be 40 millimeter of mercury. However, some of this alveolar oxygen is normally absorbed by the blood, leaving an alveolar partial pressure of oxygen of about 35 millimeter mercury in alveoli. Woohoo! Jigba has nothing to do here except for the movie Everest, which I recommend if you want to understand the effects of oxygen percentage, or you can say oxygen saturation in air. Well, you should know that at the summit of Mount Everest, only the best of acclimatized people can barely survive when breathing air. Although the situation is very different when the person is breathing pure oxygen, because breathing pure oxygen increases arterial oxygen saturation at high altitudes. You see, up to an altitude of about 10,000 feet, the arterial oxygen saturation remains at least as high as 90%. It falls progressively until it is only about 70% at 20,000 feet and much less at still higher altitudes. On the other hand, when pure oxygen is breathed, the space in the alveoli, formerly occupied by nitrogen, now becomes occupied by oxygen. And for this reason, even at 20,000 feet, aviators could have an alveolar partial pressure of oxygen as high as 139 millimeters of mercury instead of the 18 millimeter of mercury they would have when breathing air. Now, I will tell you the physiological compensatory responses which take place in response to this high altitude hypoxia. These responses are arbitrarily divided into acute and long term with specific names of accommodation and acclimatization respectively. The accommodation refers to immediate reflex adjustments of respiratory and cardiovascular system to hypoxia, while acclimatization refers to the changes in body tissues in response to long-term exposure to hypoxia. Now, as I already told you that accommodation responses of the body, they are immediate and reflex to acute hypoxic exposure. And now they consists of hyperventilation and tachycardia. But why do we hyperventilate? You see, the decreased arterial partial pressure of oxygen results into the stimulation of peripheral chemoreceptors, which means the resultant increased rate and depth of breathing. The same peripheral chemoreceptor stimulation results in tachycardia and increased cardiac output also, which would mean increased oxygen delivery to tissues, which is beneficial, right? At the same time, this stimulation also causes an increase in 2,3-diphosphoglycerate due to hypoxia and alkalosis. Now I'm going to tell you about acclimatization, which could be one of your university questions. A person remaining at high altitudes for days, weeks, or years becomes more and more acclimatized to the low partial pressure of oxygen. Here you can see in this chart that sea level alveolar partial pressure of oxygen is 104 millimeter of mercury. At 20,000 feet, it falls to 40 millimeter of mercury in an unacclimatized person, but only to 53 millimeter of mercury in acclimatized person, because alveolar ventilation increases much more in acclimatized person comparatively. In this chart, you can see the saturation of hemoglobin with oxygen at different altitudes. Up to an altitude of 10,000 feet, even when air is breathed, arterial oxygen saturation remains at least as high as 90%. Above 10,000 feet, saturation falls rapidly until it is slightly more than 70% at 20,000 feet, and much less at still higher altitudes. Now, this graph depicts effects of breathing pure oxygen on alveolar partial pressure of oxygen at different altitudes. The red curve shows arterial blood hemoglobin oxygen saturation at different altitudes when one is breathing pure oxygen. Here you can see that saturation remains above 90% until the aviator ascends to 39,000 feet. And then it falls rapidly to about 50% at 47,000 feet. What you should know about acclimatization as your university question, that is the definition at least, and then some more. You can define it as a process in which an individual organism adjusts to a change in its environment. In other words, it's the process which allows one to maintain performance across a range of environmental conditions. Acclimatization may occur in a short period of time to the alveolar partial pressure of oxygen and to work capacity. How acclimatization to low partial pressure of oxygen is beneficial? Because then the low partial pressure of oxygen, it will cause fewer deleterious effects on the body after the person is acclimatized. And after acclimatization, it becomes possible for the person to work harder without hypoxic effects and ascend to still higher altitudes. Acute deleterious effects of hypoxia in an unacclimatized person are drowsiness, lassitude, mental and muscle fatigue, sometimes headache, nausea, and euphoria. Keep in mind that when the person is breathing air, these effects start appearing at an altitude of 12,000 feet. The effects progress to twitchings and seizures above 18,000 feet and coma at 23,000 feet, followed shortly by death. The most deleterious effect is mental impairment due to decreased judgment and memory, which results in impaired performance of discrete motor movements. Let me elaborate the decreased mental proficiency with an example. See, if an unacclimatized aviator stays at 15,000 feet for 1 hour, his mental proficiency falls to 50% of normal. And after 18 hours, it drops to only 20% of normal. Now, let's start with the changes which occur during acclimatization to high altitude. There is greatly increased pulmonary ventilation achieved through arterial chemoreceptors. Then there is an increased number of RBCs. Also, increased diffusing capacity of lungs for oxygen is observed. The angiogenesis results in increased peripheral tissue vascularity. Surprisingly, there is an increased ability of tissue cells to use oxygen despite low partial pressure of oxygen. Other acclimatizing means include decreased affinity of hemoglobin for oxygen and increased cardiac output, which is increased by 20 to 30% for few days. Certain cellular changes also take place, like increased myoglobin. And then there are very interesting hypoxia inducible factors. Now, let me explain few of these effects in detail. The cause for increased pulmonary ventilation at high altitude, that is the hypoxic stimulation of respiratory centers through peripheral chemoreceptors. This compensation occurs within seconds for the high altitude, and this alone allows the person to rise several thousand feet higher than would be possible without the increased ventilation. What actually happens is that an immediate exposure to low partial pressure of oxygen stimulates the arterial chemoreceptors. This stimulation increases alveolar ventilation to a maximum of about 1.65 times normal. And if the person remains at a very high altitude for several days, the chemoreceptors increase the ventilation still more, up to about 5 times normal. Now, there is a twist of inhibition of respiratory center by increased ventilation. Actually, the immediate increase in ventilation blows off large quantities of carbon dioxide, reducing the partial pressure of carbon dioxide and increasing the pH of body fluids. Now, these changes inhibit the brainstem respiratory center and thereby oppose the effect of low partial pressure of oxygen to stimulate respiration by way of peripheral arterial chemoreceptors. However, the good news is that this inhibition of respiratory center fades away during the ensuing 2 to 5 days, allowing the respiratory center to respond with full force to peripheral chemoreceptor stimulus from hypoxia, and ventilation resultantly increases to about 5 times normal. Now, cause of this fading inhibition is the reduction of bicarbonate ion concentration in cerebrospinal fluid and brain tissue, which means there is a decrease in the pH of the fluid surrounding the chemosensitive neurons of respiratory center, which results in increase in the respiratory stimulatory activity of the center. But the critical question is why there is a fall in pH. Now here comes the compensatory role of kidneys, which support hyperventilation. Whenever there is hyperventilation, there is increased washout of carbon dioxide, which results in respiratory alkalosis. Now this alkalosis is counteractive to hypoxic drive. Here kidneys compensate by excreting more bicarbonate in the urine and also by inhibition of hydrogen ion excretion from kidneys. As a result, there is more hydrogen ion in the cerebral spinal fluid, which leads to increased ventilation. Now here I have got a scenario for you, and I want you to select the best choice of answer. You think of it as an assignment and also discuss it with your tutorial teachers. You see, this is not rocket science. It's pretty simple, but you can also use the rule of exclusion for this MCQ. Since we are discussing the changes taking place in acclimatization, so there is increase in RBC and hemoglobin. Cause for the increase in red blood cells and hemoglobin during acclimatization is again hypoxia. When a person remains exposed to low oxygen for weeks at a time, his hematocrit rises slowly to 60. Now here you should know what is the normal value of hematocrit in males and females. Anyway, the average increase in whole blood hemoglobin is up to 20 grams per deciliter. Again, if you don't know the normal values, you can't appreciate the difference. Now, the total increase in hemoglobin is up to 50% or even more because of the blood volume increase also, as the blood volume increases by 20 to 30%. Now, how does the affinity of hemoglobin for oxygen behaves during hypoxia? As I already told you, there is a decreased affinity at the lung level, as a result of which tissues get abundant supply. Cause of this decreased affinity is the rightward shift of oxyhemoglobin dissociation curve due to increased formation of biphosphoglycerate. Normal diffusing capacity for oxygen is 20 to 21 milliliter per millimeter of mercury per minute. This capacity is increased at high altitude. Even there is a threefold increase during exercise. Now the factors which cause this increased capacity, they are several, like increased blood volume in pulmonary capillary, increased pulmonary arterial pressure, increased opening of pulmonary capillaries, also the increased surface area of pulmonary capillaries due to increased lung expansion. Now the changes which take place in peripheral circulatory system during acclimatization, they can be summarized as increased tissue capillarity. There is a 30% increase in cardiac output and growth of increased number of systemic circulatory capillaries in non-pulmonary tissues. This adaptation occurs especially in animals born and bred at high altitude. And then in active tissues like right ventricle, when exposed to chronic hypoxia, there is a marked increase in capillarity. And this is a combined effect of hypoxia and excess workload on right ventricle caused by pulmonary hypertension. Cellular changes mostly occur in animals native to altitude of 13,000 to 17,000 feet. And in these animals, number and size of mitochondria increases, and quantity of cytochrome oxidase and other enzymes increases, as a result of which the effective use of oxygen is achieved. Right. So now don't forget the master switch to hypoxia, which are the hypoxia inducible factors. These hypoxia inducible factors are found in all oxygen breathing species, and they actually are DNA binding transcription factors. Now, what do they do? That they activate several genes that encode proteins which are needed for adequate oxygen delivery and energy metabolism. Normally, these hypoxia-inducible factors, they stay inactivated. But what happens in hypoxia that these HIFs, they are activated by the inactivation of HIF hydroxylases. Now, this inactivation, it results in the formation of transcriptionally active HIF complex, and that's how the switch is turned on. The genes which are controlled by the HIFs, they are genes associated with vascular endothelial growth factors resulting in angiogenesis. Then there are erythropoietin genes for the RBC production, mitochondrial genes for energy utilization, and glycolytic enzyme genes for the anaerobic metabolism. Also, the genes that increase availability of nitric oxide, which results in pulmonary vasodilation. An interesting bit which you should know about the natives of high altitude living at more than 13,000 feet, that is, they show superior acclimatization as compared to the lowlanders. In these human beings born in, for example, Peruvian Andes and Himalayas, this acclimatization begins in infancy. Now you write down the changes which we see in these Highlanders. Number one, the size of their chest is larger, and then they have large size carotid bodies. There is increased red blood cells, increased hematocrit, and increased hemoglobin concentration. Uh, Due to hypoxia-induced vasoconstriction in their lungs, they have increased pressure in the pulmonary artery, which results in hypertrophy of right ventricle. So you see that that is the reason for common belief of their large size heart. But they sure have a better ability to perform physical activity. Here you can see the oxyhemoglobin dissociation curve for high and low dwellers. And you can observe the leftward shift of the curve in mountain dwellers, as a result of which here you can see the positive effect of acclimatization on work capacity. Why there is such drastic difference in work capacity? Well, here I would use the word you guys so fondly use in vivas, obviously. Yes, obviously, decreased uptake of oxygen reduces the work capacity of not only skeletal but also cardiac muscles. I'm sure you have covered the topic of hypoxia, so here I will just briefly describe the effects of acute hypoxia at high altitude. As you all know, hypoxia can be defined as reduced availability of oxygen to the tissues. And the factors which determine the class of the hypoxia, they are the oxygen in the arterial blood and oxygen carrying capacity of the blood, then the velocity of blood flow, and also the utilization of oxygen by the cells. So on the basis of these factors, hypoxia is classified into hypoxic hypoxia, anemic hypoxia, stagnant hypoxia, and histotoxic hypoxia. And each type of hypoxia, it may be acute or chronic. Similarly, the effects of hypoxia, they could be immediate and delayed. The immediate effects of hypoxia, they are on respiration, central nervous system, blood, cardiovascular, and digestive system, also even on kidney. As far as the respiratory system is concerned, initially there is increased respiratory rate due to chemoreceptor reflex. And there is alkalemia, which is caused by the excessive washout of carbon dioxide. But later comes the failure of the respiratory center, which results in reduced rate and force of breathing and ultimately shallow periodic respiration. Central nervous system shows the hypoxic effects as cerebral edema, due to which decreased mental proficiency is observed, where there is decreased judgment, decreased memory, and decreased performance of discrete motor movements. Uh, and if the hypoxia is acute and severe, there is even sudden loss of consciousness. And if not treated immediately, coma occurs, which leads to death. Now, coming to blood and circulation. Since hypoxia stimulates the peritubular interstitial cells in kidney and increased secretion of erythropoietin, there is stimulation of red bone marrow, and the red blood cells count increases with an increase in reticulocyte count. And there is also increased hemoglobin content, and the oxygen carrying capacity of blood is improved. Well, for cardiovascular system, initially there is a reflex stimulation of cardiac and vasomotor centers, resulting in an increase in rate and force of heart contraction, which will mean an increased cardiac output plus increased blood pressure. But later, there is reduction in the rate and force of contraction and cardiac output and blood pressure. Here is the detail of different stages of hypoxia at high altitude, along with the extent of oxygen saturation. And then you can see that how the different stages they present, and they affect the respiratory and the cardiovascular system. Now you can also conclude that the hypoxic effects depend not only on the level of the altitude but also at the rate of the development of hypoxia, that whether it is acute or subacute, and also the acute or chronic duration of exposure to hypoxia matters. So, keeping all these things in mind, the clinical types of hypoxia, these could be, as you can see in this figure, these could be fulminating, acute, or chronic. And since we are talking about the clinical things, here are the clinical syndromes which are caused by high altitude, and believe me, these are important for your theory exam even. Okay. Now here in this flow chart, you can see the mechanism how pulmonary edema develops, which may occur above 10,000 feet. Now let me show you a more vivid flow chart of this mechanism, which is this mechanism is commonly seen in 75 to 80% in persons who perform heavy physical work in first 3 to 4 days of ascent, or in persons who were acclimatized to high altitude and then they stayed at sea level for more than 2 weeks and again rapidly reascended. Acute mountain sickness occurs when a person from sea level ascend to high altitude within 1 to 2 days for the first time, and it develops within 8 to 24 hours and lasts for 4 to 8 days. Uh, Here you can see the vicious circle for the development of cerebral edema during acute mountain sickness. Now, the treatment of acute mountain sickness includes large dose of glucocorticoids and an attempt of decreasing alkalosis by giving acetazolamide, as it decreases the hydrogen ion excretion by kidney by inhibiting the carbonic anhydrase. Further, we move to chronic mountain sickness, and don't get confused if an external examiner calls it Monge's disease. It may occur in long-term residents of high altitude with problems like polycythemia, cyanosis, malaise, fatigue, and exercise intolerance. Another complications of chronic mountain sickness include pulmonary hypertension, due to which you already know that right side of heart it becomes enlarged, and peripheral arterial pressure begins to fall. Ultimately, the congestive heart failure ensues and death often follows. But most people with this condition they recover within days or weeks when they are moved to lower altitude. Now, keep in mind that the major causes of chronic mountain sickness they are blood thickening, vascular spasm, and pulmonary shunt. Why does the blood thicken? You see, the RBC's mass it becomes so great that the blood viscosity increases several folds. Now, the harm is that there is decreased tissue blood flow and decreased oxygen delivery. And why the vascular spasm is harmful? Because when pulmonary arterioles they become vasoconstricted, there is a rise in pulmonary pressure which results in right heart failure. Now, how the pulmonary shunt operates? Actually, the alveolar arteriolar spasm it diverts much of blood flow through non-alveolar pulmonary vessels. So, an excess of pulmonary shunt blood flow, where blood is poorly oxygenated, and it further compounds the problem. Uh, Here are few other effects of high altitude which are considered minor but actually they are not. If you recall your previous knowledge, according to Boyle's law of gases, the pressure is inversely proportional to volume. So the trapped intestinal gas it will expand dramatically as the altitude increases. For example, at 18,000 feet and an atmospheric pressure of 400 millimeter of mercury, the volume of 1 liter it will become 2 liter, and at 30,000 feet and at the pressure of 225 millimeter mercury it will become 3 liters. The results of this rapid decompression, it could be painful distension of stomach and intestine, destruction of alveoli, tissue damage in paranasal sinuses. All these signs they mimic that of decompression sickness, which I will teach you later. Now, all of you might have witnessed the temperature change when you visit the mountains. With every 1,000 feet increase in altitude, the temperature decreases by 2 centigrade. And in winters, at 10,000 feet, the temperature could be 0 degree centigrade. At 20,000 feet, it could be minus 20 centigrade. And at 40,000 feet, it could be minus 44 degrees centigrade, and this situation is rarely pleasant. But these effects, they also depend on the wind velocity and humidity. And lastly, this is to show you that the light rays at high altitude, they could affect you by causing skin irritation. Now, it is a scenario-based MCQ for the acute mountain sickness, and you see I have highlighted the best choice in bold. But can you explain why the other choices, they are not right? Okay, let me tell you. You see, the initial response to hypobaric hypoxia at high altitudes is hyperventilation, which causes arterial partial pressure of carbon dioxide to fall, suppressing the normal drive to breathe. So the hypoxemia that results causes the symptoms associated with acute mountain sickness. But keep in mind that it is the central chemoreceptors which adapt slowly to this lowered arterial partial pressure of carbon dioxide over 8 to 24 hours. So they allow the ventilation rate to rise, and hence the symptoms, they improve. Now the RBC production and the angiogenesis, that also require weeks to months to compensate for the effect of hypoxia. And there is no evidence that altitude causes a change in the hemoglobin isoform or the pulmonary stress responses. So that was all about the high altitude physiology. Next time we will start with the aviation physiology and space physiology.